guest speaker, quit that. Our guest speaker for the month is Heather Baker, who is a licensed clinical social worker here with OU Medicine and is now in our OBGYN clinic. So she's going to talk about supporting maternal mental wellness. So I'm going to minimize our little chat box. And I saw Ann can hear too. So I will turn it over to Heather and let her take off. And then we'll just kind of check in periodically for questions, and we'll certainly allow time for questions at the end. And then just a reminder that this session is being recorded, and we will send the recording and a copy of the slides out to everyone after the webinar as well. So I'm going to turn it over to Heather.
Great, thank you, Becky. So no pressure, being recorded, that's exciting. Okay, so I am on speakerphone here in the office with Becky and Petra, and so I'll try to keep our sidebars to a minimum and try to give you as much information as we can. Again, my name is Heather Baker, and I am a licensed clinical social worker. That means that I have a master's degree in social work, which seems like forever ago since I got that, and also have gone through course training and supervision to become a licensed therapist here in the state of Oklahoma. Been in the field about 20 years, actually over 20, so I just say 20. And then much of my previous work was really with families, working with parents and their children, lots of parenting support, and then also work around child abuse and neglect and trauma and healing from trauma, as well as attachment and bonding work. So now I've kind of shifted my career towards working in OU Medicine at the OU Health Science campus. And I'm working in the OU physician's practice at the Women's Health Clinic. So that Women's Health Clinic incorporates 3 different clinics here on campus, including a clinic for dysplasia, for women experiencing dysplasia, and then, of course, the standard OBGYN clinic, which includes several physicians and the care team, as well as the Breast Institute here at OU Physicians. So lots of different people. I only work with OBGYN and a dysplasia clinic at this point. So basically my role there is as a behavioral health consultant. So that's a lot of jargon for saying that I'm a therapist in the clinic. I will say that OU Health Science is really working hard to get behavioral health integrated into its primary care clinics, as well as some specialty care clinics. And so basically, we want behavioral health personnel on site to provide support to patients in the immediate. We don't want doctors to have to say, hey, you really need to go see a therapist and work on some of these pieces while we also maybe give you medication and then not be able to see a therapist for a month. So, and sometimes I think any of us that have had that experience, they might be actually going to a place to get therapy. They do an intake for 2 hours there at that provider, and then have to come back 4 weeks later to see an actual therapist. So we do not want that happening when we can provide some of that support immediately. So that's what we're doing. So I am seeing lots of OBGYN patients, lots of pregnant moms, and postpartum moms. So, and that's where my focus is right now in the clinic. So today, I want to really talk about maternal mental health and wellness. I'm really excited to share the information with you because it really takes a village to support a family. And I think, we all have our own specialties and styles and approaches to families. But the more we understand about the various strengths and hazards that a family has to go through, the better prepared we are to roll with the punches with them. So, and the better resource we are for them. So I am a very relaxed presenter. I'm usually presenting live and not in webinar, so I'm not quite used to speaking to my desk, to the desk that I'm sitting at, but that's fine. And I'm happy to answer any questions as we go along, and I don't really see questions right now, so maybe Becky can handle that while I keep talking. Excellent.
Here's my mouse.
Oh, and of course you're a righty and I'm a lefty.
Or
okay.
Just use the arrows.
Yes. Okay, perfect. And then, so I'm going to cover a lot of common mental health concerns during and after pregnancy, and it's going to be done in really fairly broad strokes. you guys, this is not your focus, but we want you to have enough information to know what's happening and be like, oh, maybe that's what's happening. And so we want you to have enough to know how to get more help. So I'm going to share some symptoms so that you can be aware of those, and I'm going to share support ideas along the way as we go. So first of all, oh, yeah, I need to do this. Okay, so Becky, you're going to have to remind me. Okay?
That's okay.
All right. So here's your learning objectives. These are super simple. And I wanted to keep it that way so that we have time to talk about things and answer questions along the way if we need to. Okay. So if I have questions, where will those show up? Up here on the top?
They might. You can always expand that on the right,
okay.
But they'll kind of pop up too.
Gotcha.
So.
All right. Well, let me do that. That makes me feel better for some reason. Okay. All right. So you can see this slide here, expectations. I think a lot of people, when they learn that they're pregnant, they may at first be shocked. I have several moms that happens to. Like, we really didn't know that we were going to be pregnant. But once they get over that initial shock, they're really usually very happy and excited, and they begin dreaming about what may be with their new baby when it gets born, and they also begin to emotionally attach to that child, even at the very beginning. They have lots of envisioning of holding them, playing with them, doing fun things along the way. So, and there are many celebrations around pregnancy as well, and we all are very familiar, maybe not as familiar now, but up and coming new things are gender reveal parties. Those were new to me a couple of years ago. I was like, you do what? And then, but now I'm like, yeah, that's kind of fun. So we do that, and then we have baby showers, and with family, friends, coworkers, and all of the advice starts rolling in from all of those women that you work around. So what we don't talk about a lot and is often not expected is actually the reality of being pregnant. And so here you can see a few of the things that I picked up off the internet about the difficulties of pregnancy, and these images popped up, which I found to be pretty amusing. You do, first trimester, people get really caught off guard when they do have morning sickness, and they realize how severe it can be and how bad it can make you feel. You do get swollen, you get headaches, body pains, and so on. And then there's some other pieces here that are more cute and humorous, but nonetheless very real. This one about I'm sober, swollen, and hungry, approach with caution, I think is very realistic. You can't have that glass of wine anymore, and you're feeling like crud, and you feel like you're constantly eating at that point. So those kind of things are really difficult. And then on top of that, you get lots of mood fluctuations with all of those lovely pregnancy hormones that are raging through you to help grow baby appropriately. And yeah, it's very true. You either burst into tears or you feel like you're going to kill someone in the next 5 minutes in a joking manner, not real. And then sometimes you feel like you need to put this warning sign on you that just hangs around your neck that says, warning, stay away. But then you get into more sobering symptoms where you can see that piece right there with today I am feeling. Those are really beginning symptoms of depression. The hope is that lifts without any difficulties, but sometimes it does not, and it continues. And that's when we need to have moms willing to talk about it and be open with their providers so that we can get them the help that they need. They don't have to suffer, and I think that a lot of people think they can just suffer through it. One of the most telling pieces on this, though, is this piece about the only thing more exhausting than being depressed is pretending that you're not. I can't tell you how many women have told me that, and as a experiencer of depression as well, I think it's pretty much the truth. You're constantly trying to hide that you're not okay and putting on that mask of I'm great, I have a lot of energy, and I'm ready to do anything that we need to do, especially in the work environment. That seems to be the case. So there's all kinds of different symptoms, and we're going to talk about those as we go through. And when people experience these more intense symptoms, they really begin to have a sense of guilt and shame around it. lots of self-talk about, I shouldn't be feeling this way, what's wrong with me? So it's really important for us to know that these feelings are likely when they're saying that they have depression. And one of the best things that we can do to normalize that for them is to just assure them that there is help. So, I mean, you can say, you're not alone, and there is help. And those few simple words can be a real relief to moms and very normalizing for them so that they're willing to open up further and accept more help. So let's move forward a little bit and talk about kind of the whole broad spectrum, kind of perinatal mental health. I'm going to touch on the main factors in this category, and then know that my word is not the end all, and there's a ton of research that is ongoing about all of these conditions, especially in regard to, perinatal mental health. And we're constantly finding out new things. I just saw a new study about depression recently, where they may have touched on a very new and exciting form to treat, and it's totally different. I wish I could remember it right now, but my old brain is not working that way today for me, so I'm just going to be cooperative and accepting of that. But just know that we are constantly moving and developing this information, so please know that I am not be all end all. Okay, so previously everybody kind of knew about postpartum depression. For some it was a surprise, but for the most part, for the past probably 20 years, I mean, my kiddo's 24. I knew about postpartum depression when I was pregnant with her. I knew there was a chance of that. So postpartum depression diagnosis has been around for a long time. It was recognized in the old mental health diagnostic manual, and they've changed that in the newest diagnostic mental health manual to a different kind of diagnosis, but still there. And so I want you to realize, though, that it's not just postpartum depression. Pregnant and post-delivery moms, we consider that perinatal mental health. We have tons and tons of pregnant moms that are experiencing anxiety and depression, and nobody really knew what to call it except anxiety and depression, and really that is what it is. But there are special concerns and considerations with that because they're pregnant. And mental health conditions that they're experiencing before they are pregnant don't just go away because they're pregnant. So we do have several women that we visit with in our clinic that have had previous diagnoses of depression, anxiety, bipolar mood disorder, and we've even had a few, cases of schizophrenia and pieces like that. So we always have to be prepared for whatever walks in the door and how can we be supportive to them. So we're going to talk about that a little bit more in depth here. So first of all, we're going to start with baby blues. Baby blues, I think this has been kind of this best kept secret. I feel like it has been. I was never told about the potential for baby blues when I was pregnant. And I know a lot of moms have this blank look on their face when I talk to them about baby blues and the potential for that. But what we know now with research is that 80% of women experience this, 8 out of 10 women. And so we should not be ignoring that we need to be telling moms that this is happening. So the kind of the details around this for you to know is that this baby blues piece is really associated with changing body chemistry, and it's combined with adjustment to caring for the newborn. So you get all of this stress, and you get your body trying to re-regulate itself after not being pregnant anymore, and you just kind of get this perfect storm. The hope is that the deal with baby blues is that this is, you're going to get a ton of symptoms that feel like depression, and they are really depression. But the idea is that as soon as the body regulates itself, and if there's no hiccups in that, then this baby blues piece is going to lift for them within a few days to a couple of weeks. If it does not go away within that time frame, then we really need to be looking at postpartum depression diagnosis and really getting them the help that they need really rapidly. We do know now through research that postpartum depression can increase in intensity and severity very quickly. And so it's important that we, as supports to these moms become very aware that those are potentials. They don't always happen, but we need to be aware of them. And yes, please, Becky, have a question.
I raised my hand. So are there risk factors or anything that would kind of clue you into who might be at greater risk for moving into?
Excellent question. Thank you, Becky. So yeah, risk factors for perinatal mental health in general. Let me at least say that to you before I focus on baby blues with that. Really, it's about prior mental health conditions that they've experienced. If they've experienced any prior mental health conditions, they are more likely to experience them again during pregnancy, and their hormones, those lovely hormones again, magnify those symptoms. So they'll usually experience it worse and longer and more intense kind of pieces. So great question. With baby blues, same thing. You know, if you've got some anxiety and depression going during the pre-labor and delivery phase, then you really need to be looking at, are we going to get baby blues, or are we going to get a really classic syndrome of postpartum depression after, and we have to watch them closely. Also, baby blues, it's really easy to predict, you know, and sometimes it doesn't happen still, but if they have a lot of socioeconomic stressors, then they're just, I mean, it's just one more piece of stress and one more thing to deal with, and it could push that over the edge. Where if they hadn't had some of those stressors, they may not experience it. So anytime you're working with patients that you feel are having difficulty financially, or maybe their living conditions are not what they hope for, or they're struggling with family relationships and those type of things, that's something to really be on the lookout for, watching for that and helping them observe if there's anything else going on. Ways to support these moms when the baby blues do kind of pop up on them. First one is proactive. We want to predict for these moms that 8 in 10 chance you're going to experience some baby blues. We want them to know that early on. And so materials that I give to our pregnant moms now at the OBGYN clinic include that information. Just know 8 in 10, you're gonna have it. And how can you plan to help get support before you ever have the baby and you're in the hospital? Can you kind of circle the wagons with relatives and say, hey, can you provide a couple of meals a week for 4 weeks? Can I get one of you to come over and do some vacuuming and dusting for me once a week or twice a week? You know, those kind of things. Because we really want mom's resources to be available to the caring for the baby. And if we predict that this is going to happen, and it really does, then we need her resources for the baby, and we need others to then come in and fill the gaps. So, and sometimes it can't just be dads or partners. Sometimes they're dealing with all of those pieces too with mom, especially if she's really struggling with that, and they need help too. They need extra support, people to come in and help with that. So we want them to pre-plan for those things when they can. So that's one way to support. Another one is so helping them assess their support people and what they can do and how they can ask for help, because so many of us women do not like to ask for help. And so we really have to give ourselves permission to do that. And then there are depression management tools, kind of blue, you know, down in the blue, dumps blues tools that we can use for them. And we're going to get into those a little bit later. I just want to draw your attention to this cartoon that I picked up, again, off Google, but it really shows this mom developing from a baby, all, you know, through childhood and adolescence and young womanhood, into a career and working mom, and then they're surrounded by 3 babies that all need attention and help. And it is another change for us to be moms, and with each child is another change. So we really need to help moms understand that this is expected. You have a ton of changes going on in your life, and no one gets away from this scot-free. So the hope is that they're attentive to that and really helping us look for opportunities to get support. So the next slide that we're going to talk about is anxiety. I'm going to keep an eye on our time.
Oh, yes.
Yeah, okay. All right, because I'm the world's worst at that. So anxiety is so common. I wish I could have pulled good numbers to give you, but I felt so not comfortable with all of the varying numbers that I was getting that I was like, I am not saying any of those. But just the commonality of people experiencing anxiety just across the general population is huge, and it's so underreported. And we all, and I'm not talking about anxiety that's like, oh, you know, I'm a little nervous because I have this presentation today, or you know, I've got so much to do at home and at work, and I don't know how I'm going to get it all done. That is anxiety for sure. But this level of anxiety is along the lines as, I want you to imagine having to get up in front of 500 people and give a presentation. So all of the tight stomach, the sweating, the anxiousness, the shallow breathing, the trembling, that's the level of anxiety that most of these people report when they're reporting anxiety, and they have it all the time. It doesn't quit for them. And so it can be really difficult. And so I want people to also understand, think about how much extra energy it takes for you to mask those symptoms and still perform your function and role, and think about how those patients can do that. They can't usually, which means that soon they will start exhibiting symptoms of depression as well. We know that anxiety and depression goes hand in hand. It's cyclical. It's really rare that you're going to see a patient that's experiencing anxiety and doesn't have some symptoms of depression. And you will be also equally as surprised to find a patient that is experiencing depression and doesn't have some anxiety. So, but sometimes one is more hefty than the other one. So we kind of do diagnostics with those pieces. So you can see here some of the symptoms. Worrying too much, can't stop. And this is like really can't stop. They try to stop it, and it just continues. Those thoughts just keep popping in their head, and they cannot push them out of the way like we can when we're under less stress. Very difficult for them to relax. They report a lot of sleep problems, which then is an evil, evil cycle. When you can't sleep, then you have less brain energy and power to shift those thoughts away and redirect yourself. So it just keeps building. Lots of these folks tell me, I feel like I'm going to come out of my skin. And then this impending sense of doom. Not everyone with anxiety has this situation, but I would say probably 33%, like a third of the patients that I see, will tell me that they have just this overwhelming sense that something really bad is going to happen. And it's just all the time. They feel that way. They feel like they're under threat all the time, but they can't really tell you exactly what they think that threat is. So, and that all feels very bad. Common treatment for anxiety, of course, there's psychotherapy and medication, but mindfulness activities are another huge piece. So we're going to talk about a little bit about mindfulness at the very end of this presentation, just to give you some ideas about that. And then I'm going to let you guys decide, find your own mindfulness activities, because they're all over the place. And I'm sure they would be really good for breastfeeding as well, and kind of getting centered and ready, prepared, let the milk go down, you know, those kind of things. So hopefully that would be really helpful. Okay, so the next condition that we're going to talk about is depression. Okay, so we have this challenge on this slide. I'm really hoping that that link works and we get to see a video.
It might show, but we usually can't get the sound.
Darn it. Okay.
But what we'll do is send the video.
We'll send
the PowerPoint out afterwards.
Yes. And you guys watch the video.
Watch the video.
Excellent. Okay.
That's the problem with GoToMeeting.
Darn it.
Do that.
Okay. Gosh, well, we just cut 20 minutes off from presentations. I'm just kidding.
Okay.
So, So depression, again, thinking about this perinatal and postpartum. We're looking at, so perinatal includes postpartum. When we look at depression in perinatal moms, really these numbers at the very top are about postpartum depression. I think that if they were really looking at numbers for moms with depression before delivery, I think those numbers would increase. So right now, the numbers indicate to us that 1 in 7 women will experience postpartum depression within the first 3 to 6 months after delivery. What we know also is that if we were to follow those women out 1 year from delivery, 1 in 5 of those women, 20% of women, would be experiencing postpartum depression. The other piece for you to know is that partners do not come out of this unscathed. Partners also experience depression within 1 year of delivery and at 10% rate. So 1 in 10 partners will experience depression within a year after delivery. And that really has to do with change. The relationship changes, the household changes, the time needs change, the financial needs change, and it's huge. And I think people come into this underprepared at times, and these things really hit them, blindside them. The other piece I wanted to tell you also is that partners, when they have their partner is depressed and dealing with perinatal depression or even anxiety, they are 50% more likely to experience depression themselves.
That was my question.
That is a huge number. 50% of those people will also have depression. And men are much less likely than women to ask for help with that. And they also do not experience standard psychotherapy as helpful as women do. Men are fixers usually, and they need things to do rather than talk about things.
They don't want to talk about their feelings.
Yeah.
Because you're not supposed to.
Right. Kind of a feminine characteristic a lot of times in our society, and so they feel like that is not where they want to be, and they're too vulnerable.
If you want to try the link and then maximize, we're going to try the video.
We're going to try it,
and then, but let us know if you
can't hear it. Okay.
If you want to
just type in.
Over on that.
Yep. Okay, so there's an ad. Type in if you can't hear us. If you can't hear it. Oh, I can hear. Oh, wait, that's from a long time ago. Okay, here we go. Okay, can you guys hear it?
For new mom Abby Krause with a healthy
Cannot hear.
Okay,
all right. So we're going to stop it. You will be able to see this video when we pass the slides out after this. But this is, you can see here, depression during pregnancy, perinatal depression. And it's on YouTube, so it's right there. There's a lot of other ones. You can see a whole bunch of them down the line as we go forward with that. But we're just going to skip that effort altogether. Please know that I think that video is really helpful and gives you some nice statistics, kind of reiterating what I've been saying. So try to look at that if you can, because I think the more knowledge you have, the less surprise there is. So next slide, again, I just wanted to share this again. That mask is huge. People do not want to admit that they are feeling depression. It is a point of shame for people, and they feel so guilty. All of this self-talk about, why do I feel this way? I should not feel this way. I should be happy and overjoyed that I'm pregnant, that I have a beautiful baby, and I should be so grateful and thankful for this. Why on earth do I feel this way? They also feel bad about the other stressors, that their fatigue and tiredness and lack of motivation are moving them towards not being able to fulfill a lot of their responsibilities, or what they think are their responsibilities, and then they feel guilty that other people are having to pick up their slack. So know those pieces when you're dealing with folks that are having these experiences. There's one piece that I wanted to go back to, so I'm going to go back. Ooh, I can go back. That's exciting. So I for a long time did not know what anhedonia is, but I want you to know that that is just a lack of feeling joy or interest or pleasure. So these people will tell us, I used to love to swim, and now just even thinking about getting in the pool does not excite me in any way, and all I can think about is I have to go put my swimsuit on. Then when I'm done, I have to take my swimsuit off, take a shower, do my hair again, and I just can't think about it anymore. So, or crafting. I have to get all the crafts out, and then I have to think about what I'm going to do, and then I have to put it all away again and clean up my mess. That does not sound fun to me. Whereas before, they might be like, oh, I can't wait to do my creative memories and get my photo books ready for the baby pictures and all of those things. So that lack of pleasure and interest in things is really debilitating. So I want everybody to please remember that. Okay, so now we're going to move forward to bipolar mood disorders. I'm not going to say a lot about this because this requires a lot of research and knowledge and training, but I want you to know that it's out there. This is a lot of people think this is a fad diagnosis at this point, but we know that it is not a fad. A ton of people experience bipolar mood disorder, and it is really can be debilitating. It can interfere with life for life, forever. They when they're in their manic states, when they're in that energized, self-aggrandizing state, they can make some very poor decisions that can put their families in huge financial distress, themselves risking health and relationships. And so it's just so destructive unless it's managed. Unfortunately, with bipolar mood disorder, they cannot, when they're pregnant, cannot be taking the same medications that they had been taking because they have negative impacts on the babies. So we're trying to, lots of research is getting done with some of these medications to see what impacts, like how soon can we get them back on these medicines? Can that happen second, third trimester? Can that have a third trimester? Or does it have to wait until we're totally done breastfeeding even? So unfortunately, when these moms have to get pulled off these medications that have been so helpful to them, they have increased symptoms. And unfortunately, the hormones, again, they seem to be like our enemies. Create irritability, potential for destabilizing of relationships, and destabilizing of socioeconomic conditions. Again, thinking about, is there any way to mute that?
That's somebody on the other side, I think.
Yeah. So thinking about, they make these poor decisions, destructive decisions, and it creates a lot of chaos in their lives. So they're unmedicated, and they're just trying to do the best that they can and hold on for dear life. On top of that, they get panicked that they are not on these medications and know what it's been like before and get really anxious about whether or not that's going to come back for them. So it's very important for us to identify these patients in the beginning. It's really important to ask them, have you had these experiences before? And so that they can be giving us, the heads up and let us know that would be thinking about what kind of supports we need to put in place for them. Really, these patients need to be connected not only with a good OBGYN for, care of pregnancy and themselves, but also a psychiatrist and a psychotherapist. They need as much support as they can get while they're in this position. The psychiatrist can provide some medication for them. OBGYNs can too, but they don't have that specialized training, and so they're much more nervous about prescribing those things. But I know our set is very willing to communicate and coordinate care with the psychiatrist on our team to see what we can do for these moms. Some moms, we actually have to weigh the benefits and risks. Sometimes the bipolar piece is so severe for them that being without some of those mood stabilizing medications could lead to suicidality or just so much chaos in their life that we have to we just have to take the risk. So it's rare, but that does happen occasionally. Yeah, Becky has another question.
Yeah, so the OB-GYNs aren't comfortable prescribing or trying to work out appropriate medications on the psychiatric side. What about the psychiatrist prescribing for a woman during pregnancy? Do they have this? Will they? Do they have appropriate training? Do they have a professional comfort level?
Yeah, that's an interesting question.
It's on both sides.
The experience that I've had here through OU Physicians is that the psychiatry department, our OBGYNs, seem to be very comfortable coordinating care with the psychiatrists that are in our practice. And so they will communicate across phone or our electronic medical record, and they will coordinate care. So the physician will be like, this is okay, this is okay, this is okay. Here's some risks that we may be looking at. And then the psychiatrist can then say, okay, so this is the choices that we have. And so I think we're going to try this because it's lowest risk. And then we may need to work up to these things. And they can be communicating, both physicians can then be communicating with the patient about risks and, and that kind of, and benefits, that kind of thing. So it's pretty complicated. So the psychotherapist is in there just trying to create stability in therapy, meeting with them regularly, talking about coping and management skills, and just reminding them, helping them monitor that, and kind of being a cheerleader and just saying, you're doing it, or this is okay, and helping them keep realistic expectations. Okay, then we have psychosis. So psychosis is the scariest. I'd be surprised if any of you have seen it. Have you, Petra, ever seen it?
No, I've actually heard a couple people heard it recently from drugs.
Okay. Yeah, drug-induced. Yeah, I'm not even getting into that today. That's a huge one. Psychosis can occur for a patient, and that sounds so scary to people, that word psychosis in general. But what you can see here is the percentage is 0.1% of women will actually experience that. And it is, again, so very rare. If the mom, we should always expect a higher probability, but not much higher, if they're experiencing anxiety already, especially if it's at the high end of anxiety. So basically, the symptoms of the psychosis are hallucinations. That's how we know if they're what we call psychotic. And in the clinical sense, psychotic, not our everyday throw around the words sense. Often that is paired with thoughts of hurting themselves or others, and often it's the babies. So so the other piece is that then we have to also, professionals also have to evaluate the intent of those thoughts and hallucinations. So lots of moms may experience some symptoms of psychosis, and they have these anxious thoughts going through that they're going to hurt their babies. But in reality, what's happening is their brain is like reminding them, this is how bad it could be, but you're not really going to do this. And so we have to assess that. For some moms, they really believe it, and it's almost like what we call a command hallucination, where I need to go do this and hurt someone. Whereas there's another level of those hallucinations where it's just about the brain working through those ideas, and it's not a threat. And so anything we can do to evaluate that really quickly for a mom and help alleviate her fears is really important. So if at any point you have a mom that is saying to you, I'm hearing voices, or I think I'm seeing things that other people aren't seeing, you need to stop everything and get a therapist or a psychiatrist or their doctor, depending upon what your practice situation is. Sometimes that even includes needing them to get to an ER if you do not have those resources available, because this can worsen very quickly, and we do not want these moms going off alone anywhere. It's almost like having suicidality. We don't want them alone at that point. So they do need an immediate full psychiatric evaluation. Sometimes you have personnel on site that can do that for you. Other times you need an ER physician to take care of that. There will be likely hospitalization, but it's usually only for a few days. They get them on some what we call antipsychotic medications. It brings those symptoms into check and management, and they are feeling better and relieved by getting the help and can move forward in their daily life. Also, treatment is usually temporary. These symptoms do go away, not on their own. They have to be treated. But hopefully they don't have to be on those antipsychotic medications for very long. Okay, 15 minutes. All right. Man, this is smooth. I'm doing it. All right. So here we are. So to understand families that we meet with, we cannot just be looking at the outside layers, which is why I love this mental image of these stackable dolls. We need to come to our interactions with them knowing that there's more going on than we're ever going to know. I mean, when you see something or a patient is telling you something, then you need to understand that what they're telling you is like the tip of the iceberg, and that there's this huge shelf of ice behind it. And so, and not that you need to dig into it or explore it, because that'll make them push away and they'll run away from you, but just know that it's there. So listening, picking up on cues, that is one of the major ways to be supportive to our patients. And looking for their strengths. It's really important that moms know that other people think they're doing things right. So anything that you guys can do, and you guys are in such a nice position to do that, because you're working with them with their babies right there. And so you can say, oh, I love the way you're holding your baby. look at the way you're looking at baby, that, you know, you look so happy, baby looks so happy. Now be real about those observations. It's like, if they don't look happy looking at the baby, then maybe you can give them suggestions about, you know what, we're just going to fake it till we make it for a little bit. Put a smile on, and baby, you know, once we get that mood lifted, once you get help getting that mood lifted, that the baby is not going to remember that you couldn't get good eye contact for those few days, or a few weeks. So just know that finding those strengths and pointing them out to moms is really helpful. So now we're going to go to Basic Psychology 101. And yes, there's a video link at the bottom that you guys are going to have to watch at another time. And I really encourage you to watch it because it is a mind-shifting framework by Harvard. So Harvard EDU, it's wonderful. So anyway, this, of course, is Maslow's hierarchy of need. I just put it up here because even though it is Psych 101 for all of us, probably, you know, year one of college, it's just so useful. And as a social worker, I use it all the time. This helps me understand where a patient is and what kind of interventions that they're ready to have. So you can see here at the bottom that, first of all, you have to have your physiological needs met. To live, we all have to breathe, have food and water, we have to sleep, and we have to be able to urinate and defecate. So, or we're going to die. So if patients are super sick, or they are food deprived or food poor, resource poor, then they are not they're not ready to be working on their relationships with their friends. We need to get them resources for food and that kind of thing. So, and then again with safety, this is another big one for patients that I see. Security of body, employment, resources, morality, family, health, and property. And so that's a lot of jargon for basically, do they have safe housing? Do they have fulfilling pieces in their life? May not be work. They may have the worst job in the world, but it gives them money, and that's what they're doing. And do they have money to buy the resources that they need and access the resources? If they don't, please don't start talking to them about their self-esteem and confidence. That is not something that's going to be helpful to them, and it may actually make them feel more guilty that it's one more thing that they can't take care of, when in reality they need resources. So what we can do is make resources available. We can also make information available for when they're ready to look at it. So handouts on mindfulness activities for them to look at down the road, if they keep them, if they retain them, great. Feel free to do that. And then if they have room in their emotional bucket for that, they may pick those things up. They'll pick up the things that they're interested in and think that they can do. So it's good to have resources available to them. So now I want to talk about, I'm going to talk about something else first. Okay, so, and another video at the bottom. Please watch that one too, but we're going to talk about it a little bit. So the good, the bad, the ugly. I want to talk just a little bit about stress. Again, this is from Psych 101 as well, but I think it's a good reminder. Stress makes the world go round. I should have found a little picture of that.
Rotating.
Yeah. We all need a little stress to keep us motivated. It brings a little excitement to our lives and makes us feel good when we get it done. So here's some pieces that you might consider to be good stressors. Buying a new home, having a child, getting a new job, getting married, going on vacation. Still stressful. I always take a day when I come back from a vacation just to unwind from the vacation. So there's the good things in our life, but they create change and they do create stress, but they're still good for our system. Then we have this middle category, but a lot of the new stress people are saying tolerable stress. This is stress that is just a reality. We experience stress in our lives all the time, and you guys could mention probably 20 things right now, each of you, and we would have a huge list to go off of. But really, we usually implement management strategies for those. We know how to handle those stressors, and then we have in these pieces are intermittent, they're brief, and we expect a rebound, so we are not impacted by those long term. Then we have toxic stress. So this is the really bad one, and that's what the video is about. The video really talks about how it impacts our physical health. So I encourage you to watch that as well. I will say that a lot of these videos are attuned around children, but in reality, those children grow up to be the adults that we work with, and the adults are still experiencing toxic stress. And so it doesn't go away. So just think about it in that context of a bigger picture when you see these videos, instead of thinking, why is she showing these up? These are about kids. It's, well, our adults were kids. And so, and their kids, their babies may be experiencing this. So for you to know that. Toxic stress, you can read this for yourself. Intense, unrelenting, long periods, sometimes chronic or lifelong. They're destructive to health, mental and physical. So some examples of this are abuse in the environment, inadequate income that's very inadequate, resource poor, some people living in communities where there just is nothing, chronic worries, and I see patients with this all the time, all kinds of people thinking about that. So you always want to think about, with this stress piece, think about where your mom is in that continuum. And do they need any resources? Do you need to make a referral for them to kind of meet some of those lower hierarchical needs so that they can then focus more on baby and attachment and bonding and taking care of themselves? So I use this image because I want you all to remember when you were a kid floating on a raft in a pool. You're floating on that raft and your brother comes up and he nudges the raft to irritate you. Then eventually the raft floats across the pool, and he doesn't have to keep pushing you. He just does that nudge, and the raft eventually gets you to the other side of the pool. So I need you to think about that in that way when we touch our family's lives. Too much of a nudge, and you're going to get flipped off the raft. A little nudge and a lot of patience can get that raft to the other side of the pool. So think about, how hard are you nudging, and is it really helpful? So I want you just to be thinking about those things as you're working with your clients, making sure that you're not creating more guilt and shame for them, and giving those little nudges with lots of praise for strengths, all in the making. Okay, so I need not say more about this slide. Please, please, please be a good listener. I can't tell you how many patients come to me and say, I think I know everything about my therapist's life, and I don't think they heard a word I said. And so the first thing I say is, wow, you need a new therapist. You know, and it's the same for help around the community. It's not just therapists. So I encourage you that a little self-sharing is not terribly harmful, because it helps them understand that they're not alone, and that you are joining them and can kind of understand where they're coming from. But too much sharing is really destructive, and they usually shut down. That's when you'll notice that they're really quiet to you, and they really don't answer many questions past that. So just open those ears. Love the Dalai Lama's quote here: when you talk, you are only repeating what you already know, which is what I feel like I'm doing right now. But if you listen, you may learn something new. So listen, listen, listen. So I'm going to give you the best relief you've ever had. Resources. All of us try to shove and cram all of these resources in our brain. We're always thinking about, oh, what was that phone number again? Or what did they do again? No, forget all of that. Use your emotional bucket for something else. Have your clients call 211. This is one of the best resources in the state. It's in all kinds of states, not just Oklahoma, maybe in all 50, I don't know. They can either call 211, or they can go to www.heartlineoklahoma.org, and there they will find a database that they can access and search to try to find resources for the things that they're looking for. So when they call 211, they'll talk to an operator that will ask them what gender are they, what zip code do they live in, and then ask them what they're needing. And so they kind of sort the database in regard to what the patient needs, and then tell them all kinds of resources to look into. Now, they don't actually connect them. They give them the numbers and the information for contacting these resources. And they do try very, very hard to keep their resources up to date, but yes, we know that sometimes they're out of date. And so things change, especially in this changing funding world. So just predict that for the patients so they don't get too frustrated. Yeah, Becky.
Is that number certain hours or
no,
24/7?
24/7. And the database online is 24/7 as well. And it can be accessed through your smartphones. And a lot of our patients have smartphones.
And so a patient that's like really struggling, I mean, that's not like calling the suicide
Nope.
hotline or anything.
Nope,
They're
nope.
not going to triage for
Nope.
anything like that. Okay.
They are
here's where to go
connected.
get-
They are connected to the Suicide Lifeline. So like if an operator starts hearing a patient or somebody saying, I really feel like I'm going to kill myself, they will automatically change that, move that phone call over to a Suicide Lifeline. So they know, they're trained to do all of that. So just know that 211 is just a wonderful resource. But you got to predict, you know, you have to navigate it. You have to know that there's going to be some resources that they thought were in place and are not any longer. And you have to do a little footwork. Now, if your patient is super depressed and they just can't do any of this for them, then you're looking at who is another family member that I can give this information to that can help you with this, and see what they can do. Okay, we're running out of time. Okay, mindfulness.
5 minutes or something.
Yeah, we're doing okay. There's only a couple of slides left. Mindfulness. This is what I was talking about earlier, and what is one of the best treatments for anxiety. It's wonderful. And on top of that, it's really good for building stress tolerance just across the general population. I use mindfulness every day, and I think it's just a boon that people do not practice. And I would hope that they will find the gumption and the motivation to do that for them. Okay, so you can see here the components of mindfulness: awareness and acceptance. So this is really about non-judgmental awareness of the thoughts that go through your mind. And I know that sounds really hokey and fluffy, but we know now through a lot of research that is going on and is ongoing that this is very helpful for us, because we live in a society where we have no clue about the 60,000 thoughts that go through our head every day. So when you have that awareness, you can start shifting some of that thinking to a more positive bent. You can slow those thoughts down. You can dismiss thoughts that are not helpful to you. And you can be more aware of how you're actually feeling about those thoughts. And the acceptance piece is just giving ourselves a break. Everybody has negative thoughts. Everybody has thoughts, destructive thoughts. What we want you to know is that they're there, and that you say, yep, that's there. Wish it weren't, but it is. Okay, and move on. So this is what mindfulness does for us. Now, I didn't give you the actual activities because there's just so many of them. But I can email a few to you,
Yeah,
Becky, and then
we
you
can
can
send it
email out.
out.
Yeah, I could do that for you. I have a few that I really go to, and I have this one called the self-compassion pause. I'm definitely sending that one to you. I can't tell you how helpful it is. So I hope that everybody will look at that. Okay, let's talk about mood boosters really quick. This, I want to say, is intervention for depression as far as psychotherapy goes, and it's kind of the self-help activities that we prescribe to patients when they're coming to us coming to a therapist for depression treatment. So it's like the complement to all of the talk therapy. But it is also really good for your down in the dump days and kind of building stress tolerance and avoiding depression and down in the dump days. So mood boosters, meditation, we got that mindfulness thing in there again already. Breathing deep, that also is a mindfulness activity. And so I could go on and on about the research with breathing deep, but basically if you learn how to do deep breathing activities, and they can be done and nobody knows you're doing them even, and they take like a couple, not even a minute sometimes, but they're so powerful, and they can increase your oxygen consumption by 37%. To where you're like actually getting more oxygen into your blood, so you're thinking better. I mean, I just can't say enough about it. Reaching out, this means we need you to socialize. Yes, even you introverts, because I'm one too. You do have to be with people. We are human beings, and we developed in a social environment, and to be outside of a social environment for too long creates mental health problems for us. So yes, go find your friends, your family, spend a little time with them, and then go get some downtime afterwards for all those introverts. Exercise, can't say enough about it, and I'm terrible at it. But exercise is another one that's fantastic. Cycling, biking, running, swimming, yoga, Pilates. I mean, I can't tell you all of the ones to use here, but anxiety reducing would be more of the patterned repetitive movements. So like Pilates, running, bicycling, patterned repetitive movement are really good pieces for anxiety relief. And then just expending that energy is really helpful. And all of the biochemistry pieces that regulate when you're exercising, just fantastic for you. Please laugh. If you have nothing to laugh at, then turn a sitcom on and laugh. Please, it's really important. Gratitude is huge. Find a way to be grateful. I tell many patients, I want you to write a list every day of 10 things that you're grateful for, and you cannot repeat them. So, and they struggle with it for a little bit, but then they like it, and they really are helpful. It's really helpful to them. So laugh, but not least at all. You've got to be doing some self-care when you're being a support person for folks that are dealing with mental health conditions. So I put on there, know thyself. If you are not a good listener and you're a fixer, then you need to tell your patients that you're a fixer and you're not, and you know that you're not a good listener, and that it is okay for them to say, I just need you to listen to me for a little bit. Better to be self-disclosing than for them to think that you don't care, which is what they will think if you're not listening and you're just not good at it. So I want you to be aware of that. We want you to not be in a panic when you do come across patients that need these extra helps and supports. So have your referral resources prepared. If you get a suicidal client, who are you going to call? What are you going to do? If you know somebody that needs socioeconomic resources, of course, I've already given you that one. It's 211. Who also do you need for your therapy support? Like Petra can refer to me, and I will pick that patient up and call them and connect with them. So who can you call to make that happen for your patients? Prepare your internal script about, it sounds like you're having a lot of struggles right now. Would you like some help with that? Would you like some like for me to give you referrals? Some patients will come back and say, no, I've got a case manager over here and they're helping me and I'm good to go. Thanks for caring about that. But for those that need it, know that that's available, that you need to make that available to yourself, getting that internal script ready. You need to know your tolerance level. You need to know when you have heard too much and that you need to de-stress and debrief. Who's in your circle? Who can you consult with? Who can you debrief with? And who can you draw on for more ideas? And then you need your de-stress plan. How are you going to take care of yourself and kind of get some of that emotional goo off and get ready for the next set of emotional goo. So anyway, that's kind of what I have for you today. I know we're at 1 o'clock. See how perfect that was, Becky? Mm-hmm. So
we're right at the hour, so if anyone, we can stay on another little bit if there's any questions from anybody. Otherwise, we'll be sending her slides with the video links and a few other resources out by email.
Yes, and then if you have questions and you didn't have a chance to ask them here, feel free to email them to Becky, and she can forward them to me, and we'll do a little email roundtable. I'd be happy to do that. So anything? All right, I think we're going to go. Is that okay, Becky?
Yes.
All right, I'm going to let Becky do the letting go. Thanks so much for being with us, guys. We really appreciate it.
All right, and just a reminder that our last webinar of the year in December will be the second Wednesday in December, and we will actually have the Office of Perinatal Quality Improvement talking about breastfeeding and baby-friendly as a quality improvement initiative and an important package of their, perinatal QI projects. So we're always available by email, so just fire away and we'll be in touch. Thanks for everybody calling in today.